Awesome. And I drew the short straw because I had to follow all of these wonderful women that I work with on a daily basis that I admire and that I've learned so much from. It's a privilege to work with all four of you and many of the nurses that I see here. Cancer care, much like they say, raising children, cancer care takes a village, right? It's not just the oncologist, but there's a lot of moving parts in helping our patients get what they need to get through the most difficult time in their life. I was noticing as they were presenting that their slides had fun graphics, and my slides are boring. I have no graphics, but I'm just gonna rest in the piece that I have a fun topic to talk about. I'm talking about sex. So a little bit about the genitourinary effects of cancer treatments and addressing sexual health. Thank you, Tracy, for kind of segueing into that. I do not have any disclosures. So some of the key points surrounding sexual dysfunction in female cancer patients. So more than, and these are based on questionnaires, website polls that we pulled this data from. So more than 50% of female cancer patients experience sexual dysfunction. So that's a lot. And that's the women that were willing to answer yes to these questions, right? So it might be even more than that. Dyspareunia, or painful intercourse, is the most common sexual complaint among GYN, breast, and rectal cancer survivors. GYN cancer patients are more likely to have the discussion about genitourinary symptoms with their oncologist, and it's not because in the gyn-onc world we're better at pulling that out of our patients. We have a great segue into talking about it. We do pelvic exams. So, we're talking about their vaginal health and their vulvar health. It just opens the door for that when you're coming for your gyn-onc follow-up. Younger patients with treatment-related menopause, so patients that we put into menopause with our treatments, are at greater risk of sexual dysfunction. Up to 75% of patients that were polled said that they want their clinician to initiate this discussion. So it's important for us as providers, clinicians, those of us that take care of women with cancers, that we're creating a safe space by opening up this conversation, because the majority of patients are uncomfortable bringing it up themselves. So some of the barriers, the three biggest barriers that are faced when having this discussion is there's limited data to help guide management of sexual dysfunction. There are time constraints, obviously. This sexual health, it's a big onion with a lot of layers, right? And so our clinic times are not slotted to be able to have these lengthy, complex conversations with patients. So, as clinicians, we're faced with time constraints to be able to even open up that door to have that conversation. And then, of course, the lack of comfort with the topic. And these barriers, they're personal, they're systemic for both the clinician and the patient, okay? All these key points, Dr. Jernigan, who's amazing, had this idea of doing a retrospective study at UMC Cancer Center with the patients that we treat. So she recruited 3 LSU medical students that were eager to help us with this retrospective study. And we wanted to characterize the prevalence of oncologist-reported counseling for genitourinary symptoms or sexual dysfunction and identify gaps in care. So these students, they diligently, in early 2022, they diligently reviewed demographics and clinical data of 514 female patients. So essentially they did thorough chart reviews on these more than 500 patients that we see at our clinic within that time frame to investigate factors associated with screening and determine whether treatment or referral was initiated by the oncologist. So just as we suspected, pretty staggering results here. So a little over 13% of these patients during that time frame were asked about genitourinary symptoms or sexual health. Of those patients, of that 13%, about 37% reported that they had some symptoms of sexual dysfunction or genitourinary symptoms. And then the patients, this is where I have hope, is the patients that reported and the discussion was initiated, 96%, so almost all of those patients received treatment or a referral. So it was just getting to the discussion, right? Once the discussion happened, they got what they needed. So that's fantastic. Of the patients that discussed the symptoms, again, I'm not trying to promote gyn-onc here, but mostly it was GYN patients. And again, when you're getting a pelvic exam, usually we're gonna ask you about your sexual health. It's just an easy segue. And then some of the other cancers were breast, colorectal, and some hematologic and head and neck cancers. And in this chart review, we realized as well that these discussions mostly took place in the survivorship setting. So with those results, we realized there was a large gap in care, but it was an opportunity for us to address a significant quality of life issue, because sexual health really determines quality of life. If you're not healthy sexually, then your quality of life suffers, and that's just a fact for anybody, not just cancer patients. And so we got to do a better job of including this in our discussions with patients about how our treatments are going to affect their life. So what we decided to do with this retrospective study is we birthed what we call the Garnet Clinic at UMC. And so this clinic focuses on genitourinary and sexual health care for women with cancer. We also, it's also kind of overlapped into a clinic that some of the breast cancer patients or non-GYN cancer patients can also come to the Garnet Clinic and get their necessary GYN screening and GYN care. So what we did is directly after this retrospective study in the end of April 2022, we started initiating a screening checklist in the breast cancer survivor clinic. So the clinics of Dr. Locke and McKinney and Tracy, we developed this checklist, and it had 4 sexual health questions and 2 gynecologic screening questions. And if the patient answered yes to any of the question, that patient that prompted a referral to the Garnet Clinic. And this checklist was implemented during the rooming process of these patients. So either the MA or the nurse gave them the checklist. They were able to fill out the checklist while they waited for the oncologist or provider to come into the room. And then, Dr. Locke or Tracy, they were able to see, yes, they wanted further discussion, and they placed a referral to the Garnet Clinic. So the Garnet Clinic is a 1 half-day clinic weekly with 1 hour time slot. So each patient that gets scheduled into our Garnet Clinic has a whole hour, and that's necessary because it's a big conversation that we have, and it's a lengthy conversation, often included with a pelvic exam. And so from the time that we started this checklist, it was a little slow to get going, but from the end of April to December of 2022, I saw 11 breast cancer survivor patients for sexual health or GYN screening in the Garnet Clinic. 9 of those patients received treatment or referral. The other 2 were just seeing me for pap smear screening. They didn't have sexual health concerns at that time. And then in 2023, the whole checklist system kind of fell off, but at that point we really didn't. There was a lot of word of mouth going on, and the fellows clinic knew about the garden. All the fellows knew about the Garnet Clinic, and a lot of the other providers in the cancer center knew about the Garnet Clinic. And so I just in 2023 was receiving, a lot of referrals by word of mouth, and it actually expanded from just the breast cancer survivor patients. And I have seen some patients. Colorectal patients, some renal cell carcinoma, lymphoma, some neuroendocrine. So in 2023, I didn't have time to pull the data for that year on how many referrals, but it almost doubled in 2023 because it was not just breast cancer patients. I thought it was really important to mention that every single visit, I already said that they were 1 hour slots, and I spent no less than 40 minutes face-to-face time with each of these patients in every visit, and every visit that comes to the Garnet Clinic is billed as a level 5 based on time. And I highlight that because it speaks to one of the barriers, right, of addressing sexual health. And it takes, a team to be able to do this, because the oncologist, obviously with the sheer volume of patients that they have, don't have the time to spend an hour on top of everything else that they're addressing or treating their cancer or making sure that, dealing with their toxicities in the moment, trying to keep them safe from the treatments. They don't necessarily have an hour to spend with these patients to talk about sexual health. So transitioning a little bit into the causes of sexual dysfunction. So obviously the primary therapies that we use, surgeries like mastectomies, lumpectomies, in our space, hysterectomies plus or minus BSO, vulvectomies, cystectomies, colorectal surgeries. We know that chemotherapy has endocrine effects. It causes neuropathy, mucosal changes. Obviously, the radiation, there are a lot of acute injuries that occur with radiation, but then long-term effects of radiation could be like fistulas, and in the GYN world, we see a lot of vaginal stenosis, and then obviously radiation can put a woman into menopause, and the endocrine therapies. So really, I was thinking about this, and there's not any patient that comes to our clinic that's going to really be exempt from any of these primary therapies, right? We're going to be implementing at least one, but usually multiple forms of these primary therapies. And then there's the secondary etiologies: menopause, pain in the vulva or the vagina, pelvic floor dysfunction, urinary bowel dysfunction. Tracy touched on it a little bit. Fatigue, depression, mood disorder, body image, and then of course relationship factors. So what do we do with all of this information and when our patient is having some of these symptoms? Really simple to initiate, like we did in the Garnet Clinic, the sexual symptom checklist. It takes 3 minutes to complete. Multi-purpose design. It's a self-reported checklist. It helps guide discussion, and it can serve as a symptom tracker as well. So 4 easy questions. We added two more to ours, so our checklist had 6. But are you satisfied with your sexual health? Yes or no? Do you have concerns about vaginal health? Yes or no? Do you experience any of the following problems? And then you conclude that checklist with, would you like more information or to speak to somebody about these problems? And boom, you're now prompted that discussion. You've cracked the egg and it's there, and now, what do we do with it, right? So in addressing sexual health or sexual dysfunction, using the biopsychosocial model is really important, because we know that this topic is multidimensional. So biological factors are hormonal and anatomical changes. Psychological factor could be mood disorder, body image, motivation. Interpersonal is the relationship, the romantic or intimate relationship, and the communication that goes on in that relationship. And then sociocultural, involves religion, culture, and social norms. So the biopsychosocial model is not only multidimensional, addressing those four main factors, but it's also multidisciplinary, right? This topic and dealing with sexual health in our female cancer patients, we need a lot of wraparound supports, and the oncologist needs help. It's not something that a single provider can take on. So with the biological factors, oftentimes you'll be referring out to gynecology, urology, endocrinology, physical therapy for pelvic floor PT, which we utilize a lot in our GYN patients. Interpersonal factors, referring out to sex therapists or couples counseling. I have one patient in the Garden Clinic right now who has utilized couples care counseling with her partner, and they've had wonderful outcomes from the couples counseling. And her sexual health, over the last year or two has significantly improved due to the couples counseling. And being able to open that communication between her and her partner about what she's gone through and how she feels and what's important to her. Psychological factors, obviously mental health provider. So we have a great, onc-psych team that really helps us a lot, and they use a lot of cognitive behavioral therapy. I have one very young patient right now that was referred to me last year who had she's a lymphoma patient, very young. She actually had lymphoma of the cervix, B-cell lymphoma, and so she had radiation, and she's had a lot of, just all that's involved with her sexual health, but just all the side effects. And so she sees our onc-psych provider regularly and has benefited so much from seeing onc-psych. And what I love about this multidisciplinary approach is the onc-psych provider reached out to me and said, she's making great strides, she's doing good with therapy, but I really think that she would benefit from interventions and an SSRI, and obviously the psychologist couldn't prescribe that, but reached out to me and was like, would you be willing to discuss this? She's amenable. We were able to start her on a SSRI. She's continuing, in the Garnet Clinic with the onc-psych, doing well, thriving. She's in school, and this is all because it was a collaborative effort to get her there. Socially and culturally, we really need to have sensitive resources and educational materials, and then also, interpreters for language barriers. I kind of highlighted and starred here that this multidisciplinary approach, being able to do this and have these wraparound supports. When you have PAs and nurse practitioners or APPs in the clinic that you can utilize that are working in oncology or women's health, it's really a benefit to the oncologist and to the patient population because we don't have the sheer volume, myself and Tracy, we don't have the sheer volume of patients that the oncologists do, so we're able to really spend more time with the patient in the room, and it's not that the oncologists don't want to, there's just time constraints. They have, the volume of patients that they have, it's just not possible. Tracy and I have more time. We can have, visits that are an hour or so to spend time with these patients, and it also allows us to really really become experts in these topics of side effects and sexual health. I by no means think that I'm an expert or a sex therapist or an expert in sexual health. I've been doing this for 2 years and I'm learning, but I've been able to do a lot of reading and a lot of learning on my own, and just the experience of working with this patients has helped me be more comfortable talking about sexual health with my patients. So I think really utilizing APPs to help with these wraparound supports that our patients need. I'm a big proponent of that, obviously. Oh, and then one other thing too, so nurse practitioners and PAs, really any clinicians, you can get an additional certification with the Menopause Society. So it's a class that you take. I thought it was really interesting. We deal with a lot of menopause, but it's a little extra certification and learning to help add to your expertise in dealing with some of these things. Some resources that I've actually used to help me over the last couple of years. These are great websites. I use them frequently when I know that, I'm preparing for my Garnet Clinic patients and my patients that I'm going to be talking about sexual health. I own all 3 of these books. I have not read them in their entirety, but I've thumbed through them, and there's certain ones, especially for women only, A Revolutionary Guide to Overcoming Sexual Dysfunction. There's a lot of good chapters in there that have helped me in my practice. So I'm missing a slide too, my conclusion slide. So in conclusion, the key points to take away from this brief talk are more than half of female cancer patients are suffering in silence. Most of our patients are having issues with sexual dysfunction, but they're not making it known. Patients want providers to initiate the discussion about sexual health. The barriers are personal and systemic for both the provider and the patients. Sexual health screening can take place at any point during cancer care. So, our data showed that most of the time this discussion happened in the survivorship setting, but if you're going to use the symptom checklist, you could really do that early on when, you're doing their chemo teaching or throughout their actual cancers, throughout their actual cancer treatment, to get an idea of the supports that you're going to need to help this patient through their care. Using a sexual symptom checklist is a brief, effective tool, and the biopsychosocial model is a multi-dimensional and multidisciplinary approach. So thank you. I hope this brings awareness to the topics of sexual health. Also, one plug, if you haven't seen on Netflix, I highly recommend it, the show called Sex Education. It's lighthearted, but it's fantastic. Watch it.
We do have a mic up here for any questions. Don't be shy. We're all friends now. We've been in here for an hour or two. I don't need a chair. Look, there's a mic behind you. I'm just going to stand there. Hello.
So I'm kind of curious.
Oh. May need to turn it on. Let's see. Is there a button at the top? There you go.
I'm wondering how much you have seen sexual traumas or emotional traumas playing into the struggles that women have after their treatment, and also the crossover that you're seeing with the ones that may not be so obvious with eating disorders that may have been pre-existing. Because, there's this thought that women with eating disorders are less likely to have hormone-related cancers, but that's not always the reality.
I love that question. Immediately it brings to mind a patient of mine who worked in healthcare. She's doing great, but she is probably 3 years out now from her cervical cancer diagnosis. I remember, her cervical cancer diagnosis was right when COVID happened, because it was a pain. I had no idea, it was a whole mess trying to make things happen, but we made it happen. She got through treatment. But it was shocking because it was a patient who was in healthcare and knew the importance of getting pap smears and seeing the gynecologist and getting regular preventative visits, but didn't do it. And when I asked her why she hadn't done it, she gave me this story, this traumatic story about her delivery and preterm labor and all these pelvic exams and feeling like she was being examined without her consent, which, obviously is a perception of things happening in a terrible, traumatic, sure there was a lot going on in the room. But whatever that birth experience was for her was so traumatizing, she never went back to an OBGYN. And then she ended up with an advanced stage 4A cervical cancer, which is in remission now after chemo and radiation. And she is going on trips all the time and doing great things. But I think it's worth thinking about that, because it was a traumatic experience. It wasn't like a sexual assault at a frat party or something like that, but it was her birth experience that was traumatizing. I think it's important for us to remember to slow down and be sensitive, because we can traumatize these patients and scare them away from healthcare. Sometimes I think the wait in our waiting room is enough to scare people away from our healthcare.
Truly.
Do you guys have any? No, I think
Anything to add? Come on, Dr. Tang.
Excellent talk, important topic. Question for Dr. Locke and Dr. Jernigan about fertility preservation in our practice. And do you know how many percentage of women were offered service or consulted on fertility preservation during chemotherapy consultation? And if so, do we have a protocol in place? And finally, if we differentiate the type of agent that is involved, obviously hormonal therapy were very different from the chemotherapy. Among chemotherapy, alkylating agent versus antimetabolite. And do we have a set protocol in place?
So thank you for the question. We don't have a set protocol in place per se. I offer it to all my women under 50 who are newly diagnosed and coming to see me for the first time, and especially those who are getting ready to undergo neoadjuvant chemotherapy, and I have a REI that I refer the patients to. I would say out of the women that I have offered, once we start talking about cost, that number goes down drastically to those who actually attend their consultation. There's the REIs will provide free consultation, but they can't cover the meds. They'll cover everything else for the procedure. And out of all of the women that I've sent over, none have undergone any form of IVS due to cost. I had one patient recently that I referred. Now that we have this law in place where insurance companies are to cover, she did have commercial insurance, not Medicaid, and her insurance company still denied this, and we needed to get her started quickly, and so she was also not able to undergo the procedures due to cost. I don't know if your experience differs.
I mean, I think that's primarily the problem is that is the cost. I mean, I have so many patients that would do it in a heartbeat. And yes, and the REIs in town have been very accommodating. They will find a way to see the patient so that it does not cost the patient, but the cost of the meds and the treatment is just so high.
Yeah, maybe with the CAGLA and its organization, you can do from political viewpoint and not be in government or drug company for support.
Right. Well,
Yeah.
that's the goal. I mean, really to make it equitable. I mean, it's not equitable if some are able to afford it or access it and go through with it, and some people are stopped at a certain point because of cost. So, really that legislation needs to push forward. It needs to be equitable on all levels. And, most people, when they say equitable, it's just access. Okay, yes, you've gotten a visit, but we're still at a different, you have to provide more for those who need more in order for everybody to look and have the same.
And I think these disparities in what is possible for different types of patients with different payer mixes and statuses actually does have ripple effects in terms of how care providers perceive the efficacy of what they're doing. We don't like spending our time doing stuff that goes nowhere, right? And I do really worry about if you're in an environment or around a lot of patients that we might make the judgment that they won't want to do this and not offer it, and I think that would be tremendously unfair.
Yeah, and that's why during our busy practice we don't have time to discuss this. Maybe perhaps we should set up a fertility clinic, just to deal with this specifically that we can refer to, just like in genetic counseling.
Mm-hmm.
Yeah.
Thank you.
Thank you.
Hi, my name is Taylor Hunter. I'm a graduate of Howard University and currently a postbac at NIH. Thank you so much for the talks. I really appreciated them. Going back to the suffering in silence talk of the sex help, I'm really curious on the patient demographic as far as like socioeconomic status or race. I thought it was really interesting that you mentioned 96% actually received treatment and referrals once they had the opportunities to, but I'm still curious on who was receiving these treatments and referrals.
Yeah, it's a really good question. Really good question. Everything that we do on a daily basis is focusing on, trying to deliver equitable care across demographics, right? And so that retrospective study was our actual patients that we serve at University Medical Center and in our cancer center, and the majority of our patients are Medicaid patients and are limited resource. The majority of our patients are marginalized. So I don't have the exact data on the patients that have been referred to my Garnet clinic as far as their specific demographics. I focus kind of a little bit more on the different cancers, but just as a whole, our patient population, are mostly Medicaid, under-resourced, marginalized patients that don't have a lot of access.
I would guess, based on most of the things we've looked at, that about half of them would be Black or African American.
I just wanted to say that I love that. I appreciate y'all's work. I think that's great.
Thank you.
Thank you.
If you ever want to collaborate with us.
Yes.
Hey guys,
Hi,
so
Dr.
I have a
Phillips.
question. I frequently will have a cancer patient who has a family history of cancer who may have had bad outcomes, and they oftentimes arrive feeling, oh, this was inevitable and they're going to have a bad outcome. But we do better now than we've ever done. And from a survivorship perspective, I think a lot of these women live with a lot more fear about the future, and they also have a fear about their children. So we can do some things to mitigate that with genetic testing, germline testing, but I really think a lot of these women live with a cloud about their children's future and their own future, and what else can we do once we're finished with their treatment. Thank you.
I think the genetic piece is huge. She didn't go on it, but that's one of the big things that Shawna also covers for us in our GYN cancer space. We do have a genetic counselor at university now. We're really excited. She is going to be swamped. But a lot of our ovarian and endometrial cancer patients automatically meet criteria for genetic testing. And I know you're also, Tracy's also working and does a lot of the breast stuff. So I think those processes are so important, and it similarly take a lot of time. And I think you're totally right. I think the anxiety that comes with thinking that maybe you're passing genetic predispositions to cancer onto your loved ones is so real for a lot of these patients. But yeah, I think the genetic piece is huge.
And I'll just add, I guess, from the high risk standpoint, I don't know, Tracy, if you want to talk about that too. I mean, that does require a lot of time and discussion to bring the anxiety level down for patients. Sometimes it's, their anxiety can be warranted, and sometimes it's misinformation. So as much as you can to get rid of the false information that they have, introduce concrete information and support them in that so that they're able to bring that back to their families, but also then allow their family members to come in and be evaluated. I mean, we have a high-risk clinic that will evaluate those family members to give them some concrete information about their own individual risk, and then that can help to kind of make the full circle from a family standpoint. Sorry, did I take it off? You want to add anything? Yes.
I was just wondering if you guys could comment on how you think the current political climate or the future political climate is going to affect fertility, especially IVF, in Louisiana. I know that there's a barrier of cost, but there may be a barrier of companies, clinics just shutting doors on that.
Certainly.
Sadly.
I feel like I'm always an optimist, and lately sometimes it feels like that's kind of stupid. But I really think that this situation in Alabama is so just backwards, weird, and I was telling Dr. Jones this the other night, I love the like Gulf Coast hobby of just throwing shade at each other, because we all do that, right? But the situation in Alabama is so backwards, and they've taken something very political to almost a weirdly logical conclusion, and then all of a sudden all of us are like, wait, that's not like the way we want to treat human beings. And we all know people who've had babies with IVF, and we all love those babies, and we don't want to tell people they can't have kids. And so I think we have to go back to the drawing board. I don't see that spreading. I think that's going to get squashed. Yeah. And fortunately, in Alabama, there are some very powerful academic institutions like UAB that they've shuttered their clinic, and they're pushing, and they have a lot of power. And I think when that gets shut down, that will hopefully squash this. It's probably pretty clear to everyone where I stand on reproductive issues. I'm an OBGYN. And so I won't hide that without getting too political. But I think I'm very optimistic that once that gets shut down, we can hopefully, try to keep access to those things for our cancer patients. I don't think that will spread, but maybe I'm wrong. Maybe I'm being overly optimistic.
Yeah. Or at least we hope.
I hope so.
Yeah. I have a question. The whole body image. So alopecia is, a big thing that most women, it can even prevent them from even coming in to get diagnosed with anything because of the fear of losing their hair. Because to a large degree, everything else can kind of be hidden. But your hair and hair loss is something that is very hard to hide. So we have some things that can help with hair loss, although they're not always reproducible for every patient. But can you discuss kind of how that plays a role in patients even starting therapy, continuing therapy, and then as a consequence, at least how it makes them feel on the back end?
So when I see patients, I tell them typically, it's less traumatic when you cut your hair. If they have long hair, when you cut it a little bit before you start your treatment, because this is something like a woman, like this is your identity. Everyone can see this. Cut your hair a little bit before you start treatment, and when it starts to fall off, it's not as traumatic. Also, there are cranial prostheses available for patients, i.e. wig. So that's what I tell patients.
I'll have to say, in the time that I've been practicing, the thing that makes women cry the most when you consent them for chemotherapy is their hair loss. You can tell them that they'll drop their cardiac function, they'll have lung issues for the rest of their life, they may have neuropathy where they can't walk, but when you mention that they have hair loss, that's when the tears come. And so I think it's important to address. We did for a while have the DigniCap hair cooling system. And that does provide some efficacy to decrease hair loss in patients. Doesn't help everybody, and it can thin hair and not have them lose hair completely. We no longer have the system because once we sort of had the grant and the study that provided it, once it still costs money. So it's not important to insurance companies to cover something that's aesthetic. So patients have to pay for that out of pocket per every cycle. So if you're talking about a standard dose-dense AC regimen, you're talking about several grand in hair loss. And our patients in particular, they have to pay for their transportation, and they are working jobs and can't really afford something along those lines. So then we discuss other options and can guide them in that way. But it's a tough topic, and perhaps we can get some grant funding to get. I know there are other institutions in the city that do provide that for patients, but again, it's going to cost them the same amount of money to go somewhere else to get that as well. If anybody has
Just kind of Kind of piggybacking off of that, I'm just thinking about in our clinics, I do a lot of the consenting for our chemotherapy patients, and I agree that this is the most sensitive toxicity to our patients. And so when I'm consenting the patients, just to piggyback off of what what they said, is I tend to leave that for the very last side effect that I talk about, because I know that the patient is going to need time, and most of the time it's very tearful, and some of these conversations, around losing their hair can, in the emotion, they can say, I don't want to do this. And we've had patients that say, I don't want to do this. And so we give them that time and that space. It's important to give them that time and that space and acknowledge and have the empathy, of the emotion that they're going through, and giving them time. And we've had patients take weeks and then come back. And we tell them, that's okay, and we give them that space, and then they come back and they're ready. So I just think it's important not to dismiss it as, a very emotional, hard thing for patients to accept, and give them that space and that time.
I also think this is like where you can sometimes, and this isn't all cancers, I'm lucky, I only need to know about 5 cancers, unlike my medical oncology colleagues that know about everything. But we have some flexibility, for example, in the ovarian cancer space. Like, our frontline chemotherapy is carboplatin and paclitaxel, and it's like tried and true, and it works really well, and almost everybody gets put into remission with it, but you lose your hair. But there are other platinum doublets where you don't lose your hair, and it's not what I would do if I had cancer. I'd get a cool wig and I'd just lose my hair. That's just me. I have had patients say, this is a really big deal to me to lose hair, and I would take a marginal decrease in efficacy to not have to go through that. And then you be flexible, and you meet them where they are. You have options.
I'd say in the metastatic space, you always have to sort of have a taxane in general in the adjuvant setting, but we do have some leeway in the metastatic setting, so knowing what will make your patients lose their hair and what won't, especially with all this new stuff coming out that have unusual toxicities and profiles, and being able to have that shared decision with the patient. And I agree, some patients have not proceeded with therapy because of hair loss.
Very real topic. Important not to gloss over. It is quite important. Okay, I think that is the end of our session. So I hope you all enjoyed